Thank you so much. I'm super excited to have everyone here tonight or today. We're recording this for you, and I'm really excited to be talking to you about this topic today. It's a new thing for us at Spinal Diagnostics, but again, something I'm very excited to learn about and talk about with you and share with you. So we're going to talk about bowel and bladder stuff today. So these kind of symptoms can be incredibly disruptive to somebody's life. So when we're talking about bladder urgency or frequency or even incontinence, it really disrupts life on a major level. You're going to keep you from going on trips, from going and doing recreational things, sports, work, family. There's really no part of daily life that this can't and won't affect if it's unfortunately happened to you. The important thing to know is you're not alone. This is a very, very common issue. In fact, it's estimated that as many as 50 million people in this country have overactive bladder. I think it's actually a lot more than that. I have done some research and I've seen studies that estimate the prevalence of this condition upwards of 45% in the population. We have about 330 million people in this country. So if that is on the higher end, we're talking almost 150 million people. On top of that, at least another 20 million suffer from fecal incontinence. It's estimated that only half of the people who have these issues ever even talk to their doctor about it or seek out treatment. And it's important to ask why that is. I mean, I think the big obvious one is that this isn't really an easy thing to talk about. Bowel and bladder things are very personal and they can be very embarrassing. And it's just not something that people want to talk about. I think the other reason maybe they don't seek out help is because people just assume there's nothing that can be done. Unfortunately, in Western medicine, a lot of times patients just hear that from doctors about a variety of different conditions. There's just nothing else we can do. You have to live with it. And so that's sort of become ingrained, and it's just not the case. So the key to finding out what we might be able to do to help is to understand the condition in the first place. So three main types of things might be at play with bowel and bladder issues: overactive bladder, urinary retention, and then fecal incontinence. So just briefly to define each one, overactive bladder is just having sudden urges to urinate or the inability to control or hold it in. Urinary retention is when there's difficulty urinating at all or a feeling that you're not really completely emptying the bladder. So you go to the bathroom, but you feel like there's still urine there even though you're done. Finally, fecal incontinence is fairly self-explanatory. It's the involuntary loss of stool. So let's start by talking about normal bladder function. If we're going to talk about abnormal bladder function, it's definitely important to talk about normal function. So the bladder is a pretty unique and interesting organ. So throughout the day, the bladder fills and stretches as you take in liquids. When it gets to a certain point of expansion or enlargement, it sends nerve signals to the brain that tell you it's time to go. Now, at its default state, the bladder is, certain muscles at least, are contracting to hold the urine in. It's an involuntary, unconscious, subconscious contraction. But when the brain gets the signal that it's time to go, you go to the bathroom, you seek out the socially appropriate place for it and time. And then when you voluntarily relax those muscles, that is what happens with urination. So overactive bladder is an abnormal condition where those signals aren't being properly sent or received. So this is the frequent and urgent need to empty your bladder. Sometimes it's associated with urinary incontinence or the involuntary loss of urine or leakage. So we define frequency as having to go to the bathroom at least 8 times a day or more. And to be honest with you, for a lot of patients who suffer with this, they'd love to only go 8 times a day. It can be a lot worse than that. Urgency is just a feeling like I've got to go and I've got to go now. And it feels like you can't control it. So most of the time when the brain gets the signal that you have to go, it's just there. All right, I need to go to the bathroom at some point, and you deal with it again when it's kind of socially and situationally appropriate. But urgency is you got to go now. Urgent continence is associated with that, and that's where you got to go and you got to go now, but you can't make it. Finally, there's nocturia, which means going to the bathroom at night, and it's abnormal if you're waking up more than twice a night to empty your bladder. And again, I know several patients who 2 times a night would be a godsend because they're up 6, 8, 9 times a night. It can be pretty horrible. So with overactive bladder, again, there's an abnormal communication between the brain and the bladder. We don't know exactly why, but we know that there is. This is what leads to this feeling of abnormal urgency or involuntary contraction or frequency. And again, you may have to rush to the bathroom, and sometimes you don't make it, unfortunately. It is also super important to know that there's different types of urinary incontinence. There's not just the overactive bladder, which you see over here. On the opposite end of the spectrum is what we call stress incontinence. And now this is where involuntary loss of urine occurs with sudden increases in pelvic or abdominal pressure. So coughing or sneezing can sometimes cause urine leakage. Now the female urethra or urine tract from the bladder to outside is a lot shorter than in men. So this is stress urinary incontinence is definitely more common in women than in men. In fact, a lot of times it's not even coughing or sneezing, it can just be laughing really hard. Obviously, you can't control when you cough or sneeze. Sometimes you can't control when you're laughing. It might be in the middle of a movie theater, so this can be pretty uncomfortable. Lots of people do have mixed or both, so there's not always purely one or the other. This is important because if we're going to aim a treatment at overactive bladder and somebody has mixed urinary incontinence, this part of it's probably not going to improve. And that's okay. It's okay just to be able to treat one if we can, but we just have to go into it knowing that we're not going to be able to just magically cure everything. So if we switch over to bowel function, this is very, very similar. As the rectum stretches, it fills with stool, stretch receptors are activated, nerve signals go to the brain and tell you it's time to go. And again, it's typically an involuntary subconscious contraction to hold stool in, and then a voluntary relaxation of certain muscles, as well as other forces to expel the stool, but that's how it works. Now, fecal incontinence is obviously when this doesn't work. This is the uncontrolled loss of stool, which can be solid stool, liquid stool, or even just mucus. You can be associated with urge incontinence, passive incontinence, or soiling. Different forms of it exist. But again, it's the sudden urge to pass stool would be the urgency. An inability to stop it from coming out is the incontinence, with urge or without urge. So I alluded to this earlier, but it's really hard to underestimate how much this impacts quality of life. Again, there's almost no part of your daily life that this wouldn't impact, from physical participation in activities, social activities, sexual activities with your partner, working, stuff around the house and with your family. And then I think the psychological one is important. A lot of times these issues lead to feelings of shame or guilt or loss of self-respect. And also, just the fear of having accidents can dramatically limit what people choose to do. And sometimes people just don't leave the home anymore. It's horrible. So it is super important to know that what this isn't, okay? This is not a normal part of getting older. I can't tell you how many times I've heard that. Well, I just figured it's part of getting older. And unfortunately, sometimes physicians have told patients that, but it's not. It's not just a part of being a woman either. A lot of these issues are more frequently encountered in women, but they do happen in men. But it's not just part of being a woman. It's not just an issue of prostate with the men. Again, the prostate can lead to urinary issues, but that's not always the issue. Sometimes prostate issues get treated and there's still urinary issues. And it's certainly by no means anybody's fault. It's not something that anybody did. So the good news is there are treatment options available. There's very conservative ones, there's more advanced ones. So let's kind of go over these things and go over them in the context of kind of the general pathway that you would go on to explore to learn more about this and what can be done. And we'll go over kind of overactive bladder, urge, and fecal incontinence, but they're all very similar. The general pathway on the left side is you start by talking to your doctor, and that's typically going to be either your primary care physician, or in the case of females, perhaps their gynecologist or their women's health specialist. Some type of initial treatment will be initiated. That will lead to a follow-up visit with the doctor to reassess, and then, if necessary, talking about more advanced therapies. That last step is the one that often gets missed, because unfortunately, a lot of times if somebody tries the conservative therapy and it doesn't work, then that's when they're told, nothing else we can do. That's not the case. So with overactive bladder, there's going to be some initial stuff when you talk to your doctor. That's going to be talking about your symptoms, having a diary to document exactly how often and when you have the urge to go or you need to go or have accidents. You talk about these initial treatment options, which are often bladder training exercise, lifestyle changes, pelvic floor therapy, and prescription medications. Now then when you follow up, if you're doing better, fantastic, that's great. And most people probably will get some improvement. But if not, don't give up. There are other options. So there's kind of three general types of advanced options, including sacral neuromodulation, which is what I'm going to focus on. But there's also Botox and this other tibial nerve stimulation. So urinary retention pathway looks very different over here. This might have some more initial testing. You're usually going to have a urinalysis at some point to make sure there's not a urinary tract infection, which can throw everything out of whack. For the urinary retention, there might be alpha blocker medications, there might be behavioral management, again, pelvic floor therapy, and the same types of advanced therapy, but also surgical intervention can be used for urinary retention, as well as self-catheterization. If we look at fecal incontinence, similar things, similar pathway, starting with the basics, dietary changes, pelvic floor exercises, medications, and then maybe sacral neuromodulation. So the initial treatment for overactive bladder. Bladder training exercise is something that you would probably do with a pelvic floor therapist or a specialist physical therapy. Kegel exercises most people have heard of. Bladder retraining, so kind of scheduling frequent breaks during the day to go to the bathroom to try to sort of nip it in the bud, so to speak. Timed voiding, delayed voiding pelvic floor exercises. Lifestyle changes. So a lot of times you're going to have to monitor your fluid intake. Limit alcohol, limit caffeine or carbonated beverages, certainly eliminating those types of things after a certain point in the afternoon or evening. Prescription medications, there are several different classes of medications and different brand names of medications that have been used. They can be helpful, but unfortunately, all of these medications tend to have some pretty nasty side effects. So the advanced therapies. So there is something called a tibial nerve stimulation that can be helpful. This is where a small needle is placed in the ankle. It sends a nerve signal to the bladder that can help control these issues. The problem is that you're going to end up going, 12 times for a half an hour each. It's going to take long-term maintenance therapy after that. And we don't have super high success rates. Botox injections are another option that helps kind of relax the muscles of the bladder wall. That's an in-office procedure. It's relatively safe, but it is invasive and it can be pretty uncomfortable. Bigger issue with Botox is it doesn't last forever. It has to be repeated fairly frequently. Finally, there's sacral neuromodulation or sacral nerve stimulation. And this is my area of interest, mainly because I do a lot of spinal cord stimulation for chronic nerve pain in the back. This is a very similar concept. It's basically like a little pacemaker that goes in your lower back and helps to control the nerve activity in the sacral area, which can control the bladder. So like the spinal cord stimulators for pain, the big benefit of this is that you get to try the therapy first with a very minimally invasive, low risk, temporary trial with no commitment. If it works well, these little batteries can last a long time. So sacral nerve stimulation therapy. It is indicated for overactive bladder, urinary retention, and fecal incontinence when other things have failed. So again, we've talked about the abnormal communication between the bladder or the rectal area and the brain, and this stimulation aims to restore that. It's not a thing you feel typically, so it's kind of just runs in the background. You don't know it's there. It's just helping to normalize that cycle of signals between the brain and the bladder. So you definitely are going to try more conservative stuff first. This is not what you jump right into. This is for when you've tried those other things and they have failed. So you do get to do this temporary trial that I mentioned, which is pretty kind of handy. There's an external stimulator. So we put this little temporary wire in, it plugs into an external battery, and then you have a little remote control to control it. If the trial, which is typically 5 to 7 days, works very well, then we do an implant, which is the same type of procedure, but we do make a little incision and put this battery in, or a generator. This thing is tiny, especially compared to the types of batteries we have for the spine. So this thing is the size of a quarter or two. And despite how small it is, it can last 15 years. This does have to be charged. We'll talk about that. One of the benefits of this specific device, which is made by a company called Axonics, is that it is fully MRI compatible. And it's kind of neat because most stimulator devices that do have some MRI compatibility are limited to the kind of older, slightly less strong MRI system called a 1.5 Tesla. Very rare to see one of these systems be authorized or safe to use in the newer, stronger 3 Tesla MRI systems. This product from Axonics is authorized for a full 3 Tesla MRI, so I think that's a great selling point. So the little remote controller is something you can just keep on your key ring. It can adjust the types of frequency or stimulation programs, turn it up, turn it down, turn it off. It's small, it's discreet. A lot of people don't even carry it with them constantly because they don't need to. It just runs in the background. To charge it, you have a separate device that plugs into the wall and it gets charged. And then you wear this belt and you place the little charger over the battery where it is inside your body, and you just hang out, basically. You watch TV, do crossword puzzles, talk to your friends, whatever it is. Typically about an hour or less of charging. They say it's charging as little as once a month. That's definitely a best case scenario, to be realistic about it. So we're going to look at some studies that have been done. And there was a great study that came out in a urology journal last year. And when it came to charging, the satisfaction for patients was, really outstanding. I mean, 96% of patients felt like the charging frequency and duration was acceptable, and 95% of patients could charge once a week or less. So I think that's pretty acceptable. This is just showing that, it's pretty easy to do this. Again, you sit there, you read, you watch TV. You don't have to go out of your way to make extra time for it because most of us have time to do these things anyway. And again, you can carry the remote, but as this woman said, never had to use it. So a lot of times you don't even carry it with you. The same study that I mentioned showed that almost 90% of patients were happy with this after a year. That's a year after it was implanted. 90% of people are happy and reporting clinically significant improvements in their frequency and incontinence symptoms. Same study showed that, again, 93% of patients were overall satisfied with the therapy. 92% would do it again if they could. I look at a lot of literature. I do clinical research with spinal cord stimulation a lot. So I'm familiar with a lot of these papers. These are very high success rates. These are much higher success rates than we see in the spine in many cases. There's great evidence for this therapy. It's proven and it works very well. And it can help you get back to a normal life. That's really what stimulation devices, whether they're for pain or for bowel or bladder, that's what they are. These are quality of life devices. So if you have these issues, if you have thought about seeing somebody, if you know somebody, a family or a friend who has these issues, please call. We'd love to see you. I'd love to sit down with you and talk to you about where you are along this pathway, whether it be very early or whether it be very late. If it is an appropriate time to talk about an advanced therapy, we can talk about trialing this therapy here in our office and surgery center. So please don't hesitate to call. Our contact information is listed here, phone number, email, and website. So again, thank you for taking the time to watch this webinar. I really am hopeful that we are able to help you. So please give us a call. Thanks so much.